Okay, hi everybody, I'm Danny Gold and this is Kat Bolsh. We're from the Children's Hospital and we have been working on this paediatric module for the Strengthening Hospital's Response to Family Violence, which is to be done as a supplementary module to Module 1 and Module 2 of the package. We've delivered this training a number of times throughout our hospital, and so we are just going to give you some tips and advice that we've learnt from doing it in practice here. The training package that we have here today is not designed to make you an expert on family violence, and it's not designed to make you an expert on child abuse and neglect. It's to help staff to get some beginning understanding of how family violence impacts children, what it means for children to be exposed to family violence, and the ways in which we can use sensitive practice to identify, respond and explore issues around family violence in children. The same principles of sensitive practice apply, and they also apply to the staff group that you will be educating. So we always start with some sort of statement like, we understand that family violence affects many of the people in this room, and we hope that what we say today is empathic to your experiences. The package provides an overview of the impact of family violence. It gives some ideas about how to use sensitive inquiry with parents and with children. It still does focus largely on intimate partner violence, and we provide 3 case studies. There is one case study that is related to newborns, one case study that is related to a school-age child, and one case study related to adolescents, because they all present with peculiarities or particular issues that are good to identify and highlight. So we will go through the package together now and highlight some of the issues that have come up for us in the training. The session summary is, as you can see, just a note as well. We won't take you through lots of information about any one slide, but there will be quite ample notes, facilitator notes underneath some of these slides, and it's really important that you do read them and don't try and do this without the help of those notes. So, definition of family violence is a recap of what was done in Module 1, and the really important point here is the final point that says behaviour by a person that causes a child to hear or witness or otherwise be exposed to the effects of the above behaviour. That's really crucial when we're talking about paediatrics. This slide, what's on the slide talks about the different ways that children might experience family violence, including witnessing it themselves or even perpetrating it themselves. What is in the facilitator notes here is a lot of information about intersectionality, and by intersectionality we're talking about those groups who are potentially more vulnerable or more marginalised or at higher risk based on other issues that they have in their life. So that might be that they come from an Aboriginal or Torres Strait Islander background where they have had poor experiences with authorities in the past and might be fearful to talk. CALD communities who face a number of barriers both within the family dynamics and within the system. Children with a disability, particularly in relation to sexual assault, we know there's a significant increased risk and correlation with family violence. So please look at the notes and make sure you talk to those intersectionalities. This slide gives some understanding of the prevalence of family violence and how it affects children. We find this to be quite a hard-hitting slide, particularly that final statement around 1 child killed per fortnight. We almost always have questions on that. This is an Australian statistic. It's 2015 from the Australian Institute of Forensic Sciences, and we know that most of these deaths occur post-separation from family violence and generally by a family member in the context of family violence. So be prepared for a bit of a pause and some question there. This slide is what we call the adverse childhood experiences slide, which is a big and growing concept. That what this really shows is that children have experiences in their childhood that have impacts on them throughout their lifespan. Most of those experiences would cause a traumatic effect. And whilst a child might be able to successfully recover from a single trauma, such as a car accident or from a short period of exposure to a parent's poor mental health, if they experience multiple adverse childhood experiences, with limited positive experiences or supports, there is going to be significant impact on their social, emotional, cognitive functioning and their health behaviours, not just as a child but throughout their entire life. This is something that will continue to grow, and family violence is at the core of these adverse childhood experiences. Is that?
Yep.
Sorry. Now, when we're looking at this slide, this is an ad that some of you might have seen on the television recently, but he's such a good dad is a comment that we hear very often from people, including from parents themselves, who say, you know, he hurts me, but he's a good parent to his children. And we just need to dispel that myth that being a good dad is also being a good partner. We use this slide, and you can use this slide to introduce some of the myths that might permeate your thinking or the people in the audience's thinking that can impact on the way that you identify and talk about family violence. So something we often say when we're doing the training is, you know, if you had two parents come in through ED, that one was a doctor, one was a lawyer, they presented very well, the kid had some injuries or mum had some injuries, we are less likely as health professionals to ask that family about family violence. If two parents come in who clearly look dishevelled, who are unemployed, whose kids, you know, have presented several times before, we're much more likely to consider these things. And the danger of that is that we miss some early important signs of family violence and potentially don't save those children or families.
So it's a really good opportunity at this point to discuss some of those myths, and in particular around some of those stressful presentations that we have to the emergency department, where we see parents who are quite stressed, and we often excuse that behaviour as a result of the initial hospital presentation, when that's often a sign that there could be a bit more going on. So it gives a good opportunity to ask around what's going on in the home environment from there.
Yeah.
There we go.
So here we start to begin to think about sensitive practice with children and young people, and really the key message here is that it's the same. What we do here with children and young people is the same as what we do with women, as per the previous training modules. The really crucial things to think about here, though, are that there are additional issues of consent, and that we have to consider the best interests of the child. So the philosophy with working with family violence is very much about a feminist empowerment perspective and about working with where the woman's at. Sometimes when we're doing this with young people, the best interests of the child might need to take precedence over that, and so we might have to do separate assessment. Again, there's lots of notes about all of this, so I won't take you through it in great detail, but do read the notes.
So this slide is really important around noticing the signs because they are specific to a paediatric setting. Within this slide, we say it's important to highlight that these signs are part of what we would call a differential diagnosis. So it's really important, if you're seeing some of these signs across the ages, to ask a few more questions around what's going on in the family home, to try and find out if there's any other reasons affecting for why that child's actually presenting to the healthcare setting. These signs should also be used in combination with the next slide, which is around looking at signs within a parent or carer. And the common theme across these slides are actually looking at the trauma upon the child and just reinforcing the fact that family violence remains a healthcare issue as well.
And one of the things that often comes up when we're looking at this slide is people say that's every child that comes to the hospital. And that's right, it is every child that comes to the hospital, and that's really what we're trying to highlight, is that in a healthcare setting, there's not a diagnostic criteria that can indicate family violence, but that if you're seeing some of these signs, it's enough to make you question and to add it to your thinking.
Exactly.
And the same with the parent slide, which we've got next.
Yeah. So looking at the slide around asking sensitively, we introduced the concept of framing statements to start a conversation. And framing statements are really important around introducing the topic of family violence to a family member, as well as ensuring that there's a safe and confidential place to actually start this conversation. When we run the training ourselves at the Royal Children's Hospital, we often use some of our own personal examples of when framing statements have been used quite poorly and the responses that have actually been elicited as a result. One of the examples I've used before is when I've taken my own child to a maternal child health appointment, and the maternal child health nurses have to ask around family violence, and unfortunately this nurse wasn't able to ask in a sensitive way, and she turned to me and pointed her finger and she said, "You are not one of these women who are in a violent relationships, are you?" Which closed down the concept of actually talking about family violence. There was no framing statement, there was no introduction, and they didn't give a chance to have any response to it.
Yeah, and we use a similar one, which sort of comes in the framing statements or at the next step of the prompting questions, where defining what you mean is sometimes important. It might be very easy for us to say, "Are you safe?" but that might not have any context for a woman. So I use another example of a friend who in the maternity ward was asked, "Are you safe at home?" and she got very panicked and worried that she hadn't put child locks on her cupboard yet, and actually what the midwife was trying to say was, "Is your relationship safe?" But the language that feels comfortable for us to use doesn't always elicit a clear message for the person in front of you. So it's really thinking about your audience and making sure the message comes across.
As mentioned, there are 3 case studies. The first one is the newborn case study, and this case study is really important because it highlights some of the specific risks associated with pregnancy and new birth. And this particular case study highlights a number of warning signs that are all in the notes that you can easily go through. It's a really good case study to start utilising the sensitive practice, and there are some ways to actually role play it if you'd like to as well.
And I think that also this one with the newborn case study is probably good because it's still really focused on intimate partner violence and what you need to do with the mum. So this can be quite familiar and a good segue in some ways from what you've done previously.
Moving on to the next slide, questions to ask yourself is a really good way to bring up the conversations around, well, if you've noticed some of these signs and if you have actually had some of these case studies presented or similar in your own experiences, what might stop you from asking? It helps, this slide is a really good one to help facilitate some discussion, to normalise the difficulty in asking around family violence, whilst facilitating a discussion around the barriers that there may be to actually asking. And again, for practitioners, it's a good way to highlight what things might actually need to change in your healthcare setting as well.
Yeah. And I often sort of, we get them to brainstorm a few ideas, and then I often say something like, "Spot on, that's exactly what all the nurses in the previous studies have said." So it's making it safe for them to talk about those barriers for themselves, and particularly with that second question around the paediatric setting, which we come back to.
The second case study is a really common case study that we see in the emergency department, and it really highlights that children with additional care needs really need additional support, that they're vulnerable, and that the impact of family violence can actually have upon a child's health. It's important that when you're working with families and within this particular scenario to ask about the other children that are actually at home, not just those who are presenting in the actual healthcare setting. And within this particular case study, it talks about the nurse's gut feeling that something is off, and when we run the training, we talk about the importance of actually acknowledging that gut feeling and then doing something with it. And that might be asking sensitively, it might be speaking with a consultant, anything like that, but acknowledging what's going on and then acting upon it is really important.
Yep.
So asking sensitively some of the prompting questions, again, these can be changed according to healthcare setting, but we find these are the easiest ones to use when using a bit of a cascading effect and asking a child around what's going on in the family home. Sometimes we talk about Gillick competency. If that's a new concept to you, certainly go out and do a little bit of research on it and what it means around asking a child at a certain age about what's going on.
But in its most basic, it means that there is increasing rights of the child and increasing capacity of that child to have input into their own decisions.
The third and final case study is the adolescent one about Emma. Again, we find with these case studies you can use all 3 of them throughout the training or just focus on one of them if that's specific to your own healthcare setting. We find that most staff are able to identify with a patient similar to the one in this one, and a lot of the feedback we've had from the training we've run is that staff feel a bit more confident in discussing things with an adolescent than what they would with a parent at this stage. So it's a good one to talk to and to really role play some of those questions that they might be able to ask in a healthcare setting.
And I think one of the things to highlight here is that we've this point around there's a past history of exposure to family violence, so that in itself might be a risk factor, but the fact that the parents are now separated with no ongoing contact is actually a protective factor, so that's indicating that mum's done something positive. That's often a confusing point for people, but I think it's an important one to highlight.
The age of consent, again all the information's on the slide, and that there is an additional module around responding to sexual assault that you need to be aware of as well. Okay. Responding respectfully to a parent, obviously all the information's on the slide. Some of the main things that we focus on in the training is that validating and informing, those 3 statements that it's okay to talk about this, that you're not to blame, and that you deserve to be safe, are 3 very key messages. And they're key messages for 2 reasons. One, because they come from healthcare providers who are among our most trusted in the community. And secondly, it is often a direct contradiction to the messages that they're actually receiving from the primary perpetrator of this abuse as well. So really important to highlight that, and very easy responses for people to be able to remember.
I think that often becomes a bit of a aha moment for a lot of staff when we do this training, recognising that they don't have to fix a situation, that the act of asking in their role as a health professional and some simple statements, whether there's been a disclosure or not, and the power that they have as a professional to make that impact on someone, and to understand that they might be one cog along the line of people who ask and respond, and that seems to really almost alleviate some distress and realise that there's something positive they can do.
Which brings us to some of the common concerns in a paediatric setting. So fairly straightforward, exactly what Danny has said around some of the concerns around not knowing when it's safe or best to ask. But the main message that we have here is that there's obviously specific concerns for children, that it is a health impact upon a child, and that it's important that staff actually do something with their concerns. Yeah.
And again, getting people to maybe brainstorm this one initially themselves is probably good, to think about what the challenges are for themselves.
So this slide highlights some of the common risks and the need for further assessment. So obviously if a clinician's identified any of the previous signs and asked sensitively, then they're aware that that child is actually still in contact within the presence of their violent family member, then further assessment and safety planning is actually required at this stage.
And this list around the child and young person is from child protection advice. So that's a really clear list, and again to be taken in line with some of the risks associated with the parent, which we've seen in the previous training.
Okay.
And when we start developing an action plan, where this is again much the same as what you were doing for an adult, but we're asking the additional questions around: are there any children at home? Is there urgent action required? Is that action always going to be something that the parent agrees to, or do I need to consider any child protection issues that we might have to do regardless of where the parent is up to? And so this is the slide that people are often very interested in. I think what's interesting here is this slide and the one before are really highlighting where things deviate a little bit between working with an adult woman, mainly a woman or an adult, versus working with a child. So again, where we can't always go with acting at the pace that the woman wants if we identify independent risk to the child. Rather than getting too caught up on all the legal duties that people have, I think it's about giving the message about the ethics of care and the duty of care, and the fact that you're a cog in this bigger system that can help protect a woman and a child. So yes, certain groups of professionals like doctors and nurses are mandated to report around physical or sexual abuse, but it's actually about our duty as a team to keep children safe. I would talk about more along those lines, and how we can be a piece in the puzzle. So when we talk about mandatory reporting, we often say, don't let the outcome dictate what you do. So sometimes you might think that what you're reporting will not meet a child protection notification, but you don't know if teachers have also reported some incidents of concern. And sometimes it's that cumulative harm picture and the emotional harm that are really crucial when we're thinking about family violence and the impact on children. So then we talk a little bit about options and referral pathways. This slide you really need to amend to make relevant to your local context. So we've put some broad spectrum services on there for external services like Safe Steps and 1-800 Respect, because we're a statewide service. But I would be making close relationships with your local services and popping them on there, particularly around your local child protection or child first or safety hub when and if they come to your area. And also obviously put the contact details for your social work team and any policies, procedures or guidelines that guide you in this work. Just as an aside, we will in time be coming up with a statewide CPG around paediatric responses to family violence, but we can update you on that when it happens. And then we need to talk about documentation and safety. Again, this has been touched on in previous modules, but there are a few issues that are particularly important when we're thinking about children. Again, they're in the notes. The main issue being that both parents may well have legal rights to access the files. So you must be extremely careful what information is inadvertently provided to a parent that shouldn't have access to that information. For example, the release of a child's address when it's been withheld from an ex-partner. It's tricky to know where to write things most sensitively in that instance, and therefore medical alert systems, you need to check your hospital's own processes, but that's really the key. There's an example documentation there, and key messages are as they are on this slide. Best interest of the child is paramount. Family violence is a health issue with long-lasting effects. Don't do this stuff alone. Consult with your team internally and externally, and remember your obligations under mandatory reporting and duty of care. That's it from us.
Thank you.